I love talking about prematurity. I want to see a difference in our outcomes and in the impact that we're having with prematurity. So that is what I do day in, day out, in my contracted hours and in my spare time, which I don't have from very much, but we make it work. So yeah, so what I do as a preterm birth specialist midwife, I have, which I've been doing that for sort of about 4 years now. Yeah, 4 years in May. I've been supporting lots and lots of families through their journeys in new pregnancies, usually where they've had a previous history of either preterm birth or they're coming into this pregnancy with risk factors that can increase their chances of preterm birth. And these are just some of the families that I've been able to support. And I've put also there like a picture of one of our obstetricians who's amazing, Dr. Rachel Waldridge. Give a big shout out because without her, I wouldn't be here. She has trained me very well to kind of be where I am. I've been to different conferences as well. Every year we have preterm birth conference where we're learning about what's the latest innovation, what is the new evidence coming out, and how can we embed that into our clinical practice, what research is out there. So I've been doing a lot of work, also developing my own sort of research style and proposals that we can take to try and improve services for women and outcomes for babies and their families. So this is what I do. I also in my service will support women with referral. When they're referred into our service, I will manage that, make sure they get seen at the right time, at the right gestation in a preterm clinic. And we offer holistic care. So it's not just the preterm care, it's also, ensuring that other aspects of their holistic well-being are seen to. That might mean perinatal mental health. It might mean linking with other specialists, such as diabetic specialists, smoking cessation as well. So lots and lots of holistic care, as well as lots of TLC for some of these families who may have experienced loss or a traumatic previous birth as well. That's a bit about me. Why are we talking about preterm birth? What is the current state of maternity at the moment? I think, as Sue's mentioned, we know where we are. We've had reports recently to tell us the struggles that our profession is facing. Maternity services are facing unprecedented pressure. We're stretched with staffing. We're not able to provide continuity of care, even though we know it's the best model of care for women and families. Women feel rushed through appointments. They feel unheard. They feel dismissed during appointments. Birth is very complex now. There's, very low number of sort of low risk women. We don't know where they are. But now it's more complex. Families are anxious. There's a lot of uncertainty. And actually self-advocacy is becoming increasingly essential for safe and personalized care. And prematurity is a significant public health issue. Actually, up to 8% of babies every year are born prematurely. Many women who have a preterm birth don't actually have identifiable risk factors for preterm birth. And this is where the challenge lies with prematurity. It remains a leading cause of neonatal morbidity and lifelong disability as well. And families then are, left with trauma. There's fear and uncertainty, and there's a lack of understanding about their risk or lack of understanding about what has happened in that process that's led to preterm birth. And that, just to give a little bit of an idea of the cost of prematurity in the UK, £3.4 billion is spent on preterm birth every year. And the cost to care for a baby in the neonatal unit ranges from £27,000 to £95,000. So the earlier your baby is born, the more it costs to support and provide that life-sustaining, life-maintaining care for those babies. So baby born at 31 weeks, it would cost about £27,000 to support in hospital to provide the best care. And then you've got up to, if the baby is even more premature at 27 weeks, that's £75,500 to sustain, and to provide the best care for that baby. And now actually babies are being born even earlier than that. And, at the cusp of viability, we have these babies who some are being born from 22 to 24 weeks and are surviving. And so just imagine the impact there. But beyond the financial impact for the NHS, we look at the cost health impacts for these families and these babies. Neonatal death, that's significant, and it's more likely if the baby is very premature. We've got illness and lifelong morbidities that are associated with prematurity. They have lung problems if they're born too early and they need lots of ventilation. There will be issues with the way their gut works, so they're more likely to have gut inflammation and death of parts of their gut, called necrotizing enterocolitis. They're more susceptible to brain bleeds because they're just just so fragile. And these can mean that actually they end up with neurodiversity, neurological problems, and complications such as cerebral palsy, for example, and eye disease. Those are way more common in premature babies. And then that's not even talking about the cost to the poor families who are dealing with transport, just getting in and out of neonatal unit to see their precious little ones. The cost of transport, the cost of parking. I don't know about you guys, but the cost of parking in my hospital is quite significant, even for staff. So, like, we do have passes for our neonatal families, so that's great opportunity to get sort of free parking. But they've also got relatives who want to come and visit the babies. You know, there's different times of days they want to come. Sometimes women can't drive if they've had a cesarean section, so cost of taxis, things like that are all things that we don't really factor in or don't think about. And the cost of childcare if they've got older children and they're still trying to sort of maintain that balance in the household, the loss of income. There's so much that it costs when you have a preterm birth that goes beyond finances, but also significant finances as well. So that being said, what are we going to do about it? How do we identify this? What do we know that leads to preterm birth? So preterm birth is multifactorial, and that is part of the challenge that we have with trying to narrow down, pinpoint, and sort of eradicate, as it were, preterm birth. It can be caused by different types of infections that sort of increase that risk for mum and baby. Infection, significant infection can set up inflammatory processes in the body that then can trigger that labor process as well. So think if you've got a raging urinary tract infection, for example, that leads to the kidneys, your body's fighting so hard to recover and fight that infection, and it sends out lots of inflammatory agents to try and combat that infection, and some of those will be involved with setting up a higher chance of preterm labor and birth. Previous preterm labor and birth, that's usually associated with potentially a weakened cervix. So what some people might know as cervical incompetence or cervical insufficiency, which I think is a much kinder term. Where there's an inherent weakness in the cervix, that can be associated with mums coming in because they feel there's just a pressure and they're changing their discharge. And actually, you do a speculum examination, you see that they're starting to dilate, and that is quite common with that kind of weakened cervix. We've got cervical surgeries where a part of the cervix has been cut away because of abnormal cells or for treatment of cancer. So actually their cervix is artificially shorter, which means it's not able to function in the same way for some women. So many different reasons that women can end up with a higher risk for preterm birth. And one of the ones that currently we seem to be missing a bit more frequently in my area is previous cesarean section at full dilatation. Now, as you know, cesarean section rates are on the rise, almost exponentially, it feels like. And a lot of those will be emergency cesarean sections, and a fraction of those will be cesarean sections at the end of labour. And that has its own pathology that increases the risk of preterm birth. And I will touch on that a little bit later. But these women, we need to be keeping a close eye on these women. So who is affected by preterm birth? I mean, up to 8% of the population, we know that. But actually, if you're a Black or Asian woman, you are at a higher chance of having adverse outcomes, and that includes preterm birth. So when we look at our national statistics, it's sort of sitting around 8.1 according to the last National Office of National Statistics in terms of the preterm birth rate. It's slightly higher, actually, for Black and Asian women, slightly lower for your white women. So actually, you've got these disparities as well in healthcare that can increase women's chances. You've also got socioeconomic factors which can play a part in preterm birth: poverty, housing, food insecurity, poor mental health, migration barriers. There's lots of different ways in which actually women can be affected. And one of the statistics that almost floored me when I was looking into it was today when I looked at Bliss Charity, which is a great charity for providing information and support for parents who have babies in the neonatal unit, was that actually one of the studies they did found that Black mothers, babies born to Black mothers were 81% more likely to die in neonatal care. That is, like, it blew my mind. It terrified me, and being a Black woman as well, it was something that just kind of really shook me to my core. So lots of work to be doing in breaking down those barriers. So, with that being said, I really want to share with you guys a story um, that does have some sadness, but also has some joy, and it also reflects the importance of the work that we do. So, this is Joy. Joy came to us pregnant a couple of years ago, and I say to us as into my trust. She was pregnant with her first babies. She found out it was twins at an early scan. Black African lady. She had a history of they actually identified fibroids in her early pregnancy scan. So that's another thing, not uncommon to identify fibroids, especially with the ethnic group of Black African ladies. You're more likely to see it. So she presented three times in the early part of her pregnancy with abdominal pain. Again, not uncommon when you have fibroids, depending on the size and location. This can be sort of an instigator of abdominal pain more frequently. So she came in three times for abdominal pain. She was checked. She was told that everything was fine and sent on her way. She came back again around 24 weeks and 2 days with the same abdominal pain. And actually, at this point, when she was checked, they did a swab test. They took a swab from her cervix to look for certain proteins that are associated with the higher risk of preterm birth. And this test is called the actin partus swab test. And that came back positive to say that she was at high risk of having a preterm birth. So with that, those findings, we transferred her to a hospital that had a level 3 neonatal unit, which is a neonatal unit that specializes in very sick or very, very premature babies. So we wanted her to be in the right place for her babies because actually we know that this helps to improve outcomes, reduce the risk of mortality and morbidity for those babies, reduces the risk of brain bleeds, and is overall is associated with better outcomes. So we wanted her, first of all, in the right place. While she was over there, she was given steroid injections to try and help those babies' lungs mature, to increase again the rate of survival, increase lung maturation, reduce the risk of brain bleeds and gut problems as well for her babies. So what happened next? But Joy gave birth to her babies 4 days later while she was in the neonatal unit, 24 weeks and 6 days. And this is a very premature gestation. Baby Abel and Felix were born, but very sadly, Felix passed away within a week of birth due to infection and complications of prematurity. And I think if I recall the statistics, so I think it's 4 out of 10 babies actually no, it's a bit higher than that. So at 22 weeks, you've got sort of 3 out of 10 babies surviving, with 1 in 3 of those having significant risk of disability. So as the weeks go by, that increases. So I think it's about sort of 4 to 5 of the babies born at this gestation will survive, and there is still a higher rate of disability, lifelong disability associated with that. But baby Abel was born weighing 680 grams, and he spent 115 days in a neonatal unit between the level 3 unit and our level 2 neonatal unit before being just discharged home at a corrected gestational age of 41 weeks and 4 days, weighing 3.3 kilos. So that was her journey through prematurity. And she, when I had the opportunity to speak to Joy after she'd had her babies, and when Abel came back to our neonatal unit to continue the care at the local hospital. So, she talked me through some of the challenges she had faced. And she, again, all the things that we hear in the reports, and there were certain points in her journey that she felt she wasn't listened to appropriately, that she felt that things could have been done differently. She didn't feel like she had enough knowledge and to be able to speak up for herself and advocate appropriately for herself and her babies. So she, surprised to us all, including herself, she was pregnant a year later. And she made direct contact with me. So this is one of the beauties of my job, when I get the opportunity to do it how I'd like to do it without the restraints of time, is that I get to build relationships with these families and actually give them the right tools and resources where to go when they're coming into new pregnancies. So she reached out directly to me on my work contact number, telling me, "Oh my goodness, I'm pregnant. I'm totally freaking out about this. I don't know how we're going to do this." And I was like, "Right, we're here. We've got this. We're going to go for it. We're going to go for it together." She was referred early to our preterm team. She was seen early in our clinic, around 12 weeks, and very consistently throughout her pregnancy. In the early part of her pregnancy, we offered her cervical cyclage, because actually, if you've had a preterm birth around 24 weeks, you've had, adverse outcome where you sadly lost one of your babies. The options that we have for subsequent pregnancies will include the option of cervical length monitoring, where we scan your cervix regularly to check that it's staying closed and long and no signs of shortening or opening. Or we can offer you a cervical cyclage, which is a stitch procedure, which some people might have heard of, where they tie the cervix shut to give it stability and to keep it closed. Those options were both appropriate options for Joy because, again, as I've mentioned, because it was a twin pregnancy, it's a possibility that actually it was the association of having an overstretched womb with growing two babies might have been the trigger for the preterm labour. It could have also been a weakness in the cervix, but difficult to differentiate what was the cause of this. So the choice was hers, and we were happy to support her with both options. And we offered her progesterone pessary as well, which is a hormone pessary that goes into the vagina or into the back passage to just calm the womb down, try and reduce that risk of preterm labour. She opted for cervical length scanning to check her cervix regularly. So we do this between 16 and 24 weeks. And her cervix was stable throughout, which was very reassuring for us. And that kind of helped us to think, well, maybe actually that preterm birth was associated more to do with the fact that it was multiple pregnancy. But one thing I wanted to highlight to you all is that actually, aside from her 10 routine preterm clinic appointments that she had sort of between that 12 weeks and when she had her baby around 38 weeks, she had 22 triage attendances, triage and our day assessment unit as well, between 18 and 37 weeks. 10 of those were reduced fetal movements, 6 of those were for abdominal pain, 3 of those were for hypertension, and 3 of those were for scan reviews. So she had to, when you have frequent reduced fetal movements, you get put on a more frequent scan pathway. So she was having lots and lots of scans above the kind of initial care pathway that we had set out for her. So lovely little baby Elliot was born at 38 weeks and 3 days, weighing 3.1 kilos. I was privileged to be there at the cesarean birth. And it was just lovely to kind of get to that point with her, having been right at the start with her. It was a journey for us to get there. And the babies, both her boys are doing exceptionally well. They're almost the same size now because Elliot's just sort of shot up and Abel's, doing really well, very lively little one. And so that's Joy's story. So what I wanted to do is just have some reflections from this case. The impact of preterm loss or previous loss and preterm birth often affect subsequent pregnancies. You're going to see heightened anxiety. Women are going to go through a range of emotions throughout their pregnancy. There's guilt for, being in a new pregnancy. There's happiness, there's fear, there's anxiety. A lot of the time, there's mistrust of healthcare professionals. We do our best, but we don't always get it right. We may not necessarily have great follow-ups and communications. That's a real challenge for right now, at least in my unit. I don't know about if you guys are all perfect in yours, but administrative errors, because they're cutting the staffing in our admin teams. Women are not necessarily getting appointments in time. Women can't get through on the phones. All of these kind of challenges. But there's also mistrust of their bodies as well when they give birth early. And you hear terms like cervical incompetence, which I hate. But weakness in the cervix. Women feel like their bodies have let them down. So we are, as a preterm midwife, and I work with, and I know a lot of preterm midwives up and down the country are doing a lot of work to try and, hold these women and be like, right, do you know what? This happened, but, this time round, we can do much more to support you. We'll be more vigilant. Your body can do it. So there's a lot of cheerleading going on. There's a lot of TLC to try and ensure women have the best outcomes and have a point of contact as well when they're having a wobble. And that's a lot of my job is, just catching women when they're having a wobble. But our work goes beyond the clinical care and is often restorative when we get it right. Frequent attendances, as you can see, there was sort of for this one patient, well, let's look at a routine antenatal care pathway. You probably get 10 midwife appointments, maybe an obstetric appointment just to kind of, go through some of your risk factors if there are any. That may be sort of 12, let's say. Well, actually, when women have complex histories like this, it can be really resource intensive. So she had more than 30 care episodes with us. This is why getting it right is so important. And I just wanted to highlight as well, fibroid pain is real. And often the pain of a Black woman is dismissed more frequently than for any other ethnic group. And Joy gave me permission to share these photos. These were the fibroids that were imaged at her cesarean section. So I just implore all my colleagues out there, student midwives, whoever you are, whatever hat you wear, when women have fibroids and they're coming in with abdominal pain, we don't know what is going on in their bodies, what they're going through, the size of these fibroids, the impact of these fibroids, whether they might be small but degenerating and causing a significant amount of pain. So this is just some food for thought about the internal struggle of a woman that we don't always get to see. And actually, this is why I sort of was like, please, can I share this? Because people need to understand that you came in for abdominal pain more than 10 times. This is why. And we don't always get that for other women who are coming in with abdominal pain, the reasons why they're coming in. So what can midwives do? I've talked about all these things, what's not so great, where the areas of improvement need to be. But I break it down like this: prediction, prevention, and perinatal optimization. Well, I'm not going to take credit for that. That's actually Saving Babies' Lives, British Association of Perinatal Medicine. But when I relate it back to what midwives can do, what I perceive is that actually prediction, our role as midwives is to identify those risk factors. So our booking midwives are best placed to, when they're meeting those women for the first time, to really dig deep into that. When we're asking those questions, if we've got a woman who doesn't speak English, we need to be getting our translators involved so that we can really break down some of those barriers, really understand what those risks are. And if we're unsure, we need to be referring them to specialist services in relation to the area that we think they might need some extra support in. So sometimes women will be referred to my clinic. I don't think it's an appropriate referral because she's had a preterm birth by cesarean section for growth problems. That we don't think that's a cervix problem, but actually because she's had that baby maybe in a different country, or there's a language barrier, I will still invite those women to our preterm clinics, and I will still offer them internal scans to check their cervix just to make sure we haven't missed anything, because those are the women who will rock up in labour with those preterm babies. So risk assessment at every appointment, because risk is dynamic, as we all know. It changes, it varies. That 1 minute they're low risk and suddenly 3 risk factors have popped up. They need to be on blood thinners. They need to be having, blood pressure monitoring, all of these kind of things. So it's about consistent risk assessment at every contact, checking that they understand what are the risk factors for preterm birth. Do they know, that what contractions or waves of pain are coming and going, discharge that's changed, mucousy discharge, suddenly pinkish discharge, any weird funky discharge, I'm like, they should be coming in to be seeing us. Acting early on symptom identification, escalate promptly. If you're not sure as a midwife in the booking clinic, reach out to your preterm birth team. Hopefully there's more and more midwives popping up for preterm birth services up and down the country, but reach out to them. They're more than happy to connect with you. If you don't understand some risk, please reach out. We love teaching, as you can see, we love talking. So we'll be happy to explain some of these things to you if you don't understand it. Reach out to your obstetric colleagues as well, to see, is this a risk factor that needs to be escalated? Document and communicate. Make sure your documentation, shows that you have identified those risks. When we talk about prevention, we're talking about reducing the risk for women. So making sure that actually we're getting them into preterm clinics in a timely manner so that we can assess them, we can monitor their cervix if that's appropriate, or offer them the right treatment. Promote smoking cessation, because this is the single most important thing that women can do to reduce their risk of preterm birth. Most of the other things are just factors that are out of their control, but if they can stop smoking, that is one of the things that can significantly reduce their risk. Recognize and treat infections. So those urinalysis that we're doing, a screening for infection, is it burn or sting when they pee? Are they is their discharge suddenly smelly? All of these kind of risk assessments and recognition of symptoms, teaching them about that as well, so they know that actually, oh no, this isn't normal, my midwife told me to check this. Ensure timely referral, as I've said. Encourage attendance and awareness. This can be quite challenging. If women are not attending, then we can't even identify them and we can't even support them. So just driving that home about the importance, using our national bundle. So we've got Saving Babies' Lives, which sort of gives us nice sort of clear ways of supporting these women when they're coming in. And then perinatal optimization. So this is the preparation, the third P that I talk about, for encouraging timely preparation for a preterm birth when we don't think that we can stop it. So that's our steroids, our steroid injections for the mum to try and help improve optimization for the babies. We've got our magnesium sulfate, which is horrid medication. If you've ever seen a woman having magnesium or have had it yourself, it does feel like you're being set aside from the on fire from the inside out. That is how women have described it. They feel an impending sense of doom. They are red, flustered, and hot. So tell them that that's what's going to happen, so that they know that this is a normal thing with this medication. Get the fans going. Soak a pad in cold water and have it ready for the forehead. Give the partners something to do, because they're usually looking like deer in a headlight in the corner of the room, aren't they? So, get them to hold a fan or a folder or something they can use to fan, so that when they see their partner going through what looks pretty horrific, they know that it's coming. They have a job to do, and they're there to support their partners. So yeah, and your antibiotics to protect those babies from infection, which is much higher when their immune systems are lower because they're preterm and early. Communicate early with your neonatal team. They're a great source of support for those women, because they'll prepare the women for what to expect in the neonatal unit. They'll prepare them about the tubes that baby's going to have, getting breast milk early for baby, what it's going to look like when there's lots of people in the room, all there to support their baby, to give their baby the best start. And they will help you with that as midwives. And then optimizing care at birth. So as much as we can do delay cord clamping, which is vital for these early babies to help stabilize their blood pressure, reduce the risk of anemia and the need for transfusion for these babies, and just give them the best start. And working as part of that multidisciplinary team. So you're from the top down, your coordinators supporting you when you've got women coming in, your obstetricians are supporting you, your neonatal team are supporting you. It's a team effort, team preterm. So yeah, and then just, ensure that you know for yourself what the risk factors are for preterm birth, so that you can act quickly if you encounter any of these things. And just remember some of these barriers, because maybe we can overcome some of those. So late booking, we know that sometimes getting them in early is a challenge, whether they understand the way healthcare in the UK works. Missed appointments, do they understand the importance of that? Health literacy, do they know what maternity care is supposed to look like? Do they know about what normal blood pressures and normal urine samples are supposed to look like? Symptom recognition, digital exclusion. These are challenges that we're facing currently at the moment, and language barriers. We're seeing more and more translation services available, but yeah, that's something that we need to be using more of. Fear of discrimination or being dismissed. A lot of women do feel that at the moment, and lack of continuity. They're seeing different antenatal midwives at every appointment. It gets tiring trying to tell your story every time to a new face. So, but yeah, prediction tools, all of these things I'm saying only work if women can access and engage in care and can trust us as healthcare professionals to give them the best care. So this is where I implore my service managers, my leaders, my higher ups, all of the big guns. This is where you can help us as midwives to give the best care. Community champions. So we want good links with our community. So our MNVPs, we want to be able to have a hub where there's someone who's an expert in prematurity, be it the obstetrician or the preterm midwife, or someone who's a champion for preterm birth, that can sort of build those networks in the community. Use social media. Let's set up campaigns in social media to be able to get those women's stories out there. We should be empowering women with scripts. I feel like this is a huge thing, and hopefully not too hard a thing to do. Scripts for women who need to be contacting our triage to go, I'm concerned about my baby because XYZ. This pain feels like this. The bleeding looks like this. Do we have a means for them to send us pictures of? I know as midwives we love a good picture, don't we? Because it helps us to kind of visualize what's going on. The blood loss, picture of the discharge, picture of the mucus, picture of it's going to help. Visual things help. So let's empower women to be able to share that with us, so that we can then give them the best care. We want our leaders to help us, empower us from within to be able to provide the best care. We should be getting patient stories out there. This is how we get engagement from our harder to reach communities. Find champions in those communities. Get the patients to tell their stories in their native language. Let's share it. Let's get it translated. Let's do it the other way around. Rather than everything being in English, let's get it in other languages and translate it into English. Short videos, mini interviews, these are the things that are going to help us with engaging our community. That's why TikTok is on fire. That's why Instagram is really popular. People want to hear people's stories. We should be doing that on a level in the safety of an environment where we can teach and empower women. So yeah, for women, talked about what our leaders can do. Now for women, act early. know the signs of when to attend those regular contractions or waves of pain coming and going. You're noticing a pattern in your tummy or in your back. If has your discharge suddenly increased? Is there vaginal bleeding? Anything like that? How do you contact? Who do you contact? Are you still in the early stages? Is it your early pregnancy unit? Is it your maternity triage? We should be empowering them, and we should be encouraging them to know that as well. Have a contact number saved on your phone, so you're not kind of back and forth about, oh, I'm freaking out now, I'm worried about this. When you're worried about something, the last thing you want to be doing is trying to scroll somewhere to find the contact details. Keep a record of your symptoms and concerns, and bring someone with you where possible. I know it's not always possible in an ideal world. Bring someone with you who can relay some of the information you've heard back to you as well. And if you are concerned, seek a second opinion. Ask your community midwife. If you don't feel brave, like bold enough to say that in your appointment, ask your community midwife to make another referral to you. We've seen recently with Martha's Rule coming into more and more trusts as well. This is something that women need to be aware of. And trust your instinct, women. You know your body. You know when something's not right. And even if you've had a sort of a traumatic previous experience, there are things that you can do to help you identify when something's not quite right. And so I just want to finish off with this, Sue. I'll be done soon in a few more minutes, Sue. um, Cesarean section at full dilatation. I want to just talk a bit about this because I'm seeing a rise in cesarean section rates nationally, and also I think there's not a lot of awareness about this risk factor. So when you have a cesarean section at the end of labour, your cervix has become part of the lower segment of the uterus. And what do we call a cesarean section that we do? And it's a lower segment cesarean section. So actually, there's a possibility that where they're making that cut to get baby out is going to be encroaching onto the cervical tissue, so the cervical canal. But you'll never know that at the time because it's all part of the lower segment of the uterus. So this is why we want to see those women in subsequent pregnancies, because actually when all the anatomy goes back to normal, in subsequent pregnancies, what you find is you're able to see if those women are going to be at increased risk, if there is damage to the cervix, if there is a shortening of the cervix due to some kind of trauma during that cesarean section, if there's what we call a niche, or where there's sort of a little opening where there's been a scar in the cervix. We can see those during a cervical length scan, and we usually offer that around 18 to 22 weeks in a subsequent pregnancy. So women, if you've had a cesarean section, mention this. How far along did you get? Were you pushing? Did they try to get baby out with a forceps or a suction cup? Use language like that to help your midwife know what the risk is. And midwives, simplify the language that we're using. When I talk about language barriers, some of the language barriers is the terminology that we use. It's not even foreign languages or it's just, if you did you have a cesarean at fully dilated? Sometimes women don't understand that. And actually it's like, oh, when did you have your cesarean section? Was it 10 centimeters? I don't know. Were you pushing? Could they see baby's head? All of these questions can help for midwives to ascertain and identify some of those risks. So it's really about probing. Be a detective, midwives. We're so good at being detectives. So think about this when you're thinking about preterm risk. Be a detective. Go all in to make sure that we're doing the best for these women. So helpful resources. I've sent you a nice list of lovely resources that are available to support women and their families through a journey with previous preterm birth or previous loss. And as Sue's mentioned, I've also written this book, which I've basically used some of the stories that I've heard in my time as a preterm birth midwife. I've anonymized these stories, and I've sort of, a bit poetic license, I've put together a compilation of 7 stories, and then I've used those stories to provide a resource and a tool to go, women, this is what you need to ask if you face a similar situation. It doesn't have to be identical, but if you're attending maternity triage for assessment, ask questions about your cervix. Does it look normal? Do I need to take any medication? Is there something I can be doing to improve the outcomes for my pregnancy? Did you see a cause for preterm labor, or for this bleeding, or for this pain that I'm having? It gives women prompts on how to ask questions, how to confidently and boldly engage with their healthcare professionals, because that's when we see the best outcomes, when we have women who are inquisitive and curious and asking those questions, and when we have healthcare staff who are also inquisitive and curious and asking those questions, and spending time to actually get to know women and understand some of those risk factors as well. Tommy's is a fountain of all good things in relation to preterm birth. 5 times more report. If you haven't read any of that, I implore women, service users, women, healthcare professionals, midwives, nurses, and anyone and everyone, read about the women's experiences of Black and brown women accessing healthcare. What does it look like? And what does it feel like to be someone who's read those reports, who is Black or brown, accessing care and worried about how you're going to be perceived. So think about that when you're caring for women from global majority backgrounds. Anyone who's not non-English speaking, think about those barriers, those challenges to care. Sometimes they've accessed care in foreign countries and they're just happy that they can access care here, and they'll take the bare minimum and they'll put up with the bare minimum. That's not what we want for our women. Birth Rights is also their Bliss organisation. And yeah, you know, if anyone wants to purchase a copy of my book, there's got an ebook and it's a hard copy as well, all available on Amazon. So thank you all very much for listening to me waffle on for so long. I just want to say a big thank you to all midwives out there, because you do make a difference. And I know that it's been challenging over the last few weeks, years, months, like the whole time. It's just ongoing. But you are making a difference to women, and please keep going. Please persevere. You know, the women that you've impacted know, and they will feel that forever. You are a part of so many women's journeys. You make a difference. Your assessments, your actions, your advocacy, it counts, and it can buy those babies weeks, extra weeks in the womb. Thank you very much.